Hello, good afternoon everyone. My name is Francisco. I am based here in London and I'd like to wish you all a good afternoon and I hope you enjoy the lecture today. We're going to have some time for some questions at the end, and I would like to keep it as interactive, at least in the end, as we can. I hope that I bring you some food for thought and that this will have some impact on your daily practice. I'm originally from Portugal, from Lisbon, and that's where I lived all my life. And then once I finished dental school, I practiced for a couple of years in Portugal, and then I moved to New York, where I was enrolled in the Implant residency in NYU under Dennis Tano chair, and that's where I've completed my training. And then once I've finished my training there in New York, then I came back to London, where I've been practicing for the past 8 years, and I've started as a clinical director in another practice, and then at some point I've opened my own practice. And the work that I'm going to show you today, this is work that I did here in my practice. So these are my patients, real patients, and I would like to share some of it with you. And London, as we know, and I'm sure that some of you have visited London, it's a fantastic place, fantastic city with lots of things to offer, very multicultural. It's a city where you have many events happening all at the same time, and definitely one of the main events that we had in the past couple of years, in the past 4 years in this case, were the Olympics in 2012, and it was a fantastic event. Everybody in London, so all the Londoners and everybody that was living in London at the time was very committed, and it was a great chance for us to see some of these amazing superstars, and one of the biggest superstars from that event, from the Olympics in 2012, was this man that we can see on the left side of the screen, Usain Bolt, Jamaican, that has set up the record, the world record for the 100 meters sprint in 9.64 seconds. So that was a great mark that he set up. About 50 years earlier than that, an American in the same competition in the Olympics, in this case in Tokyo in 1964, the same 100 meters, the final of the 100 men's 100 meters, he established the mark in 10.06 seconds. So what I want to say, and what I want to bring up with this, is that we have almost 50 years of history separating these two photos that I've just showed you, and it's incredible that in 48 years we have just 0.42 seconds of improvement. I mean, I think it's quite remarkable if we think about the sports, the industry. So many things certainly have changed. The clothes, the shoes, the methodology of the training, the diet of the athletes, so many things, and we, or in this case the athletes, they could just improve less than half a second in their best time. And I think sometimes this is something that happens also in our profession. It happens also in dentistry. Maybe into the eyes of someone else, some of the numbers that we speak with our patients, they may not seem relevant, but to us that we deal with this every day, this is very relevant, and it may mean the world to our patients. Let's say that I'm walking down the street I'm happy with my teeth, I don't have any problem, and let's say that for some reason I slip and I break one of my central incisors. I mean, it's quite of a drama because I was happy with my smile, I was happy with my tooth, and suddenly I have a complicated situation that I have to deal with. And so I go to the dentist, I knock on the dentist door, and I mean, usually the first question is, can you help me? Can you do anything for me? And then the dentist says, okay, let me just take a look. Let me just probably take some x-rays and do a clinical observation. You will ask some other questions. And a lot of questions will arise to my head as a patient in this case. And I will ask those questions. We hear those questions all the time. Is it possible to do something for my tooth? Can you put my tooth back? And then if not, if the dentist says, no, unfortunately we can't put the tooth back, or we need to look for another solution because the tooth needs to be extracted, then the next questions are, can you leave it as it was? Because I was happy with my tooth. I mean, the tooth didn't have any problem. I just slipped and for some reason I broke my tooth, but I would like to find a solution that could give me my tooth back as it was looking. I was happy. I didn't have any issue with that. And that's when we tend to start to scratch a little bit our head, and we start to do a bit of a dance. That's what we call the dance. Oh, you know, well, everybody heals differently, and we don't know. We need to look at your gums. We need to look at your other teeth. Are you a smoker? We need to see if that will have an impact. So that's when we start to be a little bit grey to our patients. We don't give very objective answers sometimes, and the patient is quite anxious. That's not what the patient wants to listen, for sure. And we know that from our side, from the moment that we need to move on and propose a treatment plan to our patients, there are so many variables that we have to deal with. So let's say that patient that came to our office, so the one that I was simulating, needs really to have the central incisor extracted. And what are those variables? I mean, the first one is if we need to extract the tooth, and how are we going to do it? Are we going to open a flap? Are we going to do it as atraumatically as possible? What instruments am I going to use? And then the question is, do I have enough bone? Is the socket intact? Can I place an implant straight away, or should I have to wait? And should I just wait, or should I do a socket preservation? Or maybe if I can place the implant, what implant am I going to place? Is it going to be tapered? Is it going to be parallel wall? Am I going to leave a gap? Should I graft the gap? Should I do a soft tissue graft? And then in the end, what kind of temporary crown I'm going to use? I'm going to use a fixed temporary crown on the implant. Am I going to use a Maryland bridge, a denture? I mean, so many questions. And the fact is that all these questions will have an implication on the treatment plan that we're going to offer to our patient. And we all know that the patients, they feel, they sense if we are secure in our decision or not. And we have to feel secure as well, because we need to find somehow a way to give a predictable outcome to our patients. So I think that predictable is really the word that I would like to explore with you at this stage. And the question is, can we predictably do an extraction and replace that tooth immediately with a dental implant? Can we have predictable results when you do such treatments? So that's for some reason a word that we are sometimes afraid of, and I would like to explore it here with you and give you some numbers and to give you a protocol. In the end of the day, we all like our recipes. We all like to do things a little bit different. Oh, I like to do that procedure in that way, but then I like to give it my own twist. And I do it myself in my practice. I am a clinician and I also do it. But the reality is that as much as we stick to the protocols, the more predictable will be the outcome of our treatments. So that's what I would like to explore here with you today. And the reason why we have to create sensible treatment plans and treatment plans that will give us that predictability is exactly to avoid situations like this. I mean, this is perhaps someone that didn't have any knowledge of biology, and they started most likely a treatment plan without any rationale, and then just to avoid situations like this to happen, we need to understand the numbers, we need to understand the literature to see exactly where we're heading to. So I'm going to divide my lecture here in 3 parts. One of them will be, the first part will be the background. I'm going to give you a bit of a background and a protocol. Then I'm going to show you some of my clinical cases, and then we're going to close up with, wrap up with some conclusions. There are many socket classifications available. I like this one mainly because it's very easy to understand. We can divide the sockets in 3 types. This is a classification that was proposed by Tano in 2007, and basically the socket type that we're going to focus today, and my lecture focus on, is the socket type 1. But I'm going to just to run you through the 3 types of sockets. So socket type 1 is where the buccal plate, as you can see here, is present, and also the soft tissue is present. So they are both present. So if we need to remove the tooth, we know that the buccal plate is there and the soft tissue is there. So everything is there, really. Okay? So these are the situations when we would like really to preserve what we have. We don't really want to augment what we have because, as I was explaining before, it's one of those situations when there was, for example, there was an accident or for some reason there is a failing crown, but the buccal plate is there and the soft tissue is there. Sockets type 2, they are the dangerous ones. Why are they the dangerous ones? Because the buccal plate is missing, or at least a greater part of the buccal plate is missing, and the soft tissue is present. And why are these the dangerous ones? Because in these kind of sockets, if we try to place an implant, we will in some situations be able to place that implant, and we will be able to engage the implant in the bone, and most likely that implant will integrate. And the problem is that the soft tissue, because it's not supported by the buccal plate, it may start to recede. And if the soft tissue starts to recede, then we start we have to deal with a big problem, because basically we'll have a very complicated aesthetic problem. So the implant will start to show, will get contaminated, and then we need to start all sorts of grafting procedures. We need to propose all sorts of grafting procedures to our patients in order to cover that implant that for some reason got exposed. So in a situation like this, it's very complicated then to justify ourselves with the patient. And then there is another problem, which is also a financial problem. I mean, we did the treatment, the patient paid the treatment, and then the patient comes back a couple of months later or a couple of years later with a big soft tissue recession on the buccal aspect of the implant, and then someone will have to pay for that. So, I mean, that's a very uncomfortable conversation that then we'll have to have with the patient. So either we bite the bullet and we do it without charging anything to the patient, or I mean, this is then, it will be personal, but this is just, I'm just trying to make my point here that we have to be very careful with these kind of sockets. So sockets type 2, be careful. I'm not saying that we cannot do it, but they mean danger. Sockets type 3 are the obvious ones. So the buccal plate is missing, the soft tissue is missing. So we know that we need to augment the site first in order to be able then to place our implant and do our aesthetic rehabilitation of the area. So type 1, buccal plate is present and soft tissue is present. Type 2, buccal plate is missing and the soft tissue is present. And type 3, they're both missing, so buccal plate is missing and soft tissue is missing. And we're going to be here focusing on sockets type 1. Another thing that I would like to discuss with you, and this is very important in order to understand the biology of the sockets and to start to to predictably understand the outcome of our treatment, we need to understand what are the sources of blood supply of our buccal plate. And this is going to be critical, because that little piece of bone that we have there, that will mean the world to us in order for us to be able to deliver a predictable final result to our patient. And the first source of blood supply to the buccal plate is the periodontal ligament. And the periodontal ligament is extremely vascular. Just for you to have an idea, the periodontal ligament has is composed, about 20% of the composition of the periodontal ligaments are blood vessels. So it is extremely irrigated, but we know that if we're going to extract a tooth, that's a source of blood supply that we will necessarily compromise. So we will be relying on the other two sources of blood supply, which will be the periosteum and the marrow. So if the periosteum is such an important source of blood supply, it's very critical that we leave it in place. And this is just to explain to you that it is critical when we do these kind of approaches that we don't open flaps. So these extractions that we do, mainly in the aesthetic area, they have to be as atraumatic as possible. We have to try to be as conservative as possible without opening the flap, without raising the flap from the bone, because we know that even if we are extremely talented surgeons, and if we do amazing sutures after we do our procedures, if we open the flap in order to see better, because this is usually the excuse, I want to see better, so I need to open the flap. What happens is that periosteum will take about 4 to 5 days to re-anastomose again. So that means that during those 4 to 5 days, that little piece of bone, that buccal plate, will be very vulnerable and most likely will suffer some alterations. And then the third source of blood supply is the marrow. But the marrow is, in some situations, inexistent. You can actually see here in the diagram that this represents, so this dark brown area represents the marrow, and here the more, the lighter yellower part, this is mostly cortical bone. And most of the times, really, the buccal plate is composed by cortical bone, which is very avascular. So if we think about the buccal plate, don't think that there is much marrow there. So there is very little blood supply there. So in the end of the day, it's the periosteum that will really represent here our main source of blood supply to the buccal plate. And a couple of people have looked into this in the past. One of them was Mariano Sanz with the competency group. They were searching something else, but also they looked into the width of the buccal plate. And just to show you that the thinner it is the buccal plate, the less marrow component it has, so more cortical it would be. And 64% of the cases that they opened, they had 0.5 millimeters or less in width of the buccal plate. And about 95% of the cases, they had less than 1% of less than 1 millimeter of buccal plate. So the buccal plate is extremely thin and very avascular. Another thing that we need to look at, that lots of other researchers, they have looked into this in the past, and in fact these authors that I'm showing you here, they are the classic ones, the ones that we consider the classic ones. These authors basically, they have looked into the dimension of the buccolingual dimension of the socket after an extraction. So if we ask to a student in dental school, we ask them, so what's the buccolingual changing, the buccolingual dimension change after we do an extraction? So what should be really here the answers? And if you look here to the right column, these are the numbers that all these very renowned researchers they found. Basically, we can see here from 4.43, 4.56, 3, 265, 5.9. So this means what? This means that all these authors, they have measured their cases, and after the extraction was performed, their cases, they got about 4 to 5 millimeters of buccolingual resorption. So, I mean, it's quite scary, and it seems a little bit exaggerated, these numbers. On the more positive note, the vertical change was a lot less. So we can see here -1 millimeter, -1.5. I mean, it's an average of 1 millimeter in vertical and about 4.5 to 5 in horizontal. So why is this? How do they get to these numbers? Basically, the vertical change is related with the fact that the palatal wall is quite thick and that holds pretty well the height of the bone after we do an extraction. So that's a very good thing actually for us. So mainly because it's very difficult to gain vertical height via a graft. So we know with this that the vertical component is more or less stable. So there is 1 millimeter of bone loss. We can deal with that in vertical. But this buccolingual resorption of 5 millimeters, it's really, really a lot. Now, when we look into all these articles, we see that all of them, they have open flaps, which is exactly what I was explaining that we should not do. We should not open a flap. So we should do our extractions as atraumatically as possible. So what happens if we don't open a flap? What's the numbers? I mean, some other researchers, they've looked into this, and it seems that the common number that they got to is 1 millimeter. So if we don't open a flap, instead of losing 5 millimeters of buccolingual dimension, we lose about 1 millimeter. So this is quite a good progress. So we have it right now. If we don't open a flap, we have a credit of 4 millimeters compared to if we open a flap. So this is something for us to have in mind. So let's do here our case selection. So as I explained to you before, the cases that I'm going to show you here and that will apply to this protocol are sockets type 1. So the buccal plate is present and the soft tissue is also present. So that's something that we need to have in mind. We also need to look into the interdental bone. And why is this so important? Because if we don't have interdental bone, we may have absence of papilla interproximus. So we may end up with a partial or with a papilla covering partially the interdental space. And this is very important, so we have that discussion previously with our patients. When we perform the extraction, we need to utilize some specific armamentarium. We need to do the procedure as gently as we can. So we can either use some periotomes, we can use these forceps, these big forceps. These I really recommend you to have a pair of these at least in your surgery. They're fantastic. They're very thin and they grip very in a very apical area, the root or the tooth in this case, at the moment of the extraction, allowing us to do circumferential movements. So we don't do any more those buccolingual movements that we learned in dental school. No, we should really, mainly if we're dealing with I mean, here the lecture is about anterior teeth, so they have just one root, so we should just apply rotational movements to the tooth. And if you want to go more fancy, then you can also use the piezotome or the piezosurgery in order to help you to remove atraumatically or as atraumatically as possible the teeth. In terms of, so let's say that we atraumatically removed our tooth, and what's the next step? Well, we need first of all to see exactly how much bone we have apically to the socket. In order to be able to engage the implant and to give some primary stability, it's important that we have at least 3 to 4 millimeters of bone apical to the socket. So that's the first thing that we need to make sure, because if for some reason I have the nasal fossa here just 1 millimeter below or apically to my socket, then it's going to be very difficult for me to engage the bone and give primary stability without entering really the nasal fossa. So this is critical to see if we have that basal bone there. Then once we start to do our drilling, I like to start my drilling with the Lindemann burr, which in this case, some of the implants that I've placed, they are from Implant Direct. This is a company that I work with on a regular basis, and this is usually their first drill. So I create first of all a purchase point on the palatal wall. I actually like to enter the sockets at 45 degrees. Sometimes my nurse thinks that I'm going a little bit crazy with the angulation, but this is really important, because if you just put here your burr completely parallel to the axis of the tooth, what happens is that at the moment that you try to engage the palatal wall, it will slip to the apical part of the socket. So I recommend you to approach the socket in this 45-degree angulation. And then you just follow your drill sequence. The main drill really is the pilot drill. It's going to be the first one that will allow us to see how thick and how hard is the bone. That will give us an idea of how much we need to undersize our osteotomy in order to give that good primary stability that we want. Okay? When we place the implant, and when we do our drilling, and then when we place the implant, what I like to do, and I would like to invite you to read this article. I like to follow this 3-2-2 concept. So what's this the 3-2-2 concept? This is a concept that Dr. Cooper has developed, and he published this in 2013. So basically, following his principle, we should displace the implant 2 millimeters towards the back of the socket. So if we draw a line in the middle of the socket, if we should displace our drill and then our implant 2 millimeters towards the palatal side and 3 millimeters down, to allow enough running room here, to allow enough emergence profile to our temporary and our final crown. Once we place the implant, then the implant will follow that same concept, so the 3-2-2 concept, and we will create on purpose a gap in between the implant, in between our implants and the buccal plates. So that's the implant in position. Here you can see the healing abutment in position. And the question is, what should we do about the gap? I mean, is it okay to leave a gap? I know that there are many theories about the gap, and this is what I would like to explore a little bit with you and to see if it's really necessary to bone graft the gap. So let's look at the gap from these 3 different perspectives. Let's look at the gap, first of all, from a survival point of view. Is leaving a gap will have any influence on the survival rate of our implants? Well, lots of researchers, they've looked into this. I'm very familiarized with Edgar Elshar. He's the head of periodontics of NYU, right in my residency, and he's actually the researcher that presents the highest N value. And as you can see, the success rate of all these studies is pretty high. I mean, we can see here success rates of 100%, 97%, 95, 95, 98. The question is this different from the success rate of an implant placed in pristine bone without, so not in a socket? Well, I don't think so. So the success rate is pretty high, and definitely here the primary criteria in order to be successful is to allow primary stability to our implant. So if we give primary stability to the implant, having a gap or not having a gap will not have any impact on the success of our immediate implant. So that's the first thing that we need to look at. Then from an osseointegration point of view, should we leave a gap or should we not leave a gap? I mean, there is this very classic study that we all like to quote, Akimoto and Beckett. I mean, it's a study from 1999, so it's a study now with 17 years. I mean, it's not new. So basically in this study, what the author did was, in order to see what would be the implications of the gap, in the same animal specimen, that they have drilled 4 different cores with different widths. So basically on those cores they placed an implant, and they left different sizes of gaps around around that implant. And then what they did was they closed the flap on top of the implants, and they opened it a couple months later just to see if they had bone around the implant or not. So basically the theory from the article is that if we have a gap of less than 1 or 1.5 millimeters, we'll have bone. If we have a gap there is more than 1.5 millimeters, we would have a soft tissue or a long junctional epithelium. But again, I mean, just like those studies that we saw from the extraction, we're talking about classic studies, and everybody's usually a little bit worried about questioning these authors. I mean, they are very well known in the lecture circuit. But the reality is that also in this study there is a problem. So what's the problem? The problem is that they've closed the flap on top of the implant, which is exactly what we're not going to do, because as I was explaining, following this protocol, we should not open a flap. So we should keep the soft tissue, the periosteum in position, and then we just place our implant. Here in this study, they're closing a flap. So what they're really doing is they are creating a pedicle of soft tissue on top of the gap. What that will create is a situation where basically the soft tissue will compete at a different pace with the bone. Let's look here to this image on the right side. So let's say that that's our implant. I've placed my implant in position, following the 3-to-2 rule, and now I have here just my gap, and I'm not going to do anything to the gap. What do you think that we're going to have here on top if we do nothing? I mean, first of all, the first thing that we need to understand is that the soft tissue needs blood supply to grow, right? So the soft tissue grows at a pace of 1 millimeter a day, but it needs to have some source of blood supply. The issue is that inside of the gap, inside of what used to be the socket, we have just a bunch of dead cells, and those dead cells, they don't give any kind of blood supply here to the soft tissue. So the soft tissue will grow more or less at the same pace as the bone will grow here inside of the gap. So that's really important. So what we're going to have here is a true competition in between the bone, the bone growth and the soft tissue growth in this area. If we open a flap, of course that if we open a flap and if we try to attempt to close the flap here on top, what we're going to create is a pedicle. So of course that then the soft tissue will grow a lot faster than our bone. So for that reason, it will create an invagination here of soft tissue on the surface of our implant. So what would be the problems of raising the flap? As I explained to you before, the first one is that we're going to sever our main source of blood supply to the buccal plate. But then apart from that, we're going to displace the mucogingival junction. As I explained to you, we're going to expose the buccal plate, which can allow resorption. And also, we're going to allow connective tissue from the flap to migrate to the surface of the implant. And that will contaminate, or at least will create a long junctional epithelium in the surface of our implant, which is not really what we want. So we know, with all these explanations, what I want to tell you is that if we don't open a flap, and if we leave our implant, and if we leave our gap, even if we don't fill it with a bone graft, we'll end up with bone inside of that gap. So we don't necessarily have to fill the gap in order to have bone against our implant. And some researchers that have looked into this, one of them was Dennis Tano. He has contributed with these findings, and nowadays we should stick here to the principle. Now the other question is, we will get bone in the gap, but we need to understand if from an aesthetic point of view, what will be the impact of not filling the gap. So that's what I would like to run you through right now. And that's when we come here to the dual zone true PT concept. And I recommend you really to read this article. I mean, this is available online. You can get it easily, and it explains the step-by-step This is actually, right now, this is a series of 3 different articles. They came up with the first one where you have the protocol, but then they came up with the numbers, and you will be able to understand better what is this thing about the dual zone concept. Basically, the dual zone concept is a concept that explores the stability not just of the bone. So we're not just looking at the maintenance of the buccal plate, but nowadays we look mainly to the stability of our soft tissue, really, because that's the soft tissue is what's going to give the frame to our final crown. So in this study, what the authors, what they did, this is a multi-center study, and what they did is they divided each of the patients in 7 reference points. So basically, these patients, they needed to have an anterior tooth extracted, and that anterior tooth, and all the sockets, there were sockets type 1, so that's a very important part of the material and methods of this study. And then they divided each one of the patients in 7 reference points that they have addressed along the duration of the study. Basically, there are 4 treatment groups. In the first treatment group, what was done was simply the extraction, atraumatic extraction, so without raising any flap, and then an implant was placed with a healing abutment in position, and nothing was done in the gap, so no graft material was placed in the gap, and no temporary crown was placed. On the study group number 2, the implant was placed, so the extraction was done, the implant was placed, and a temporary crown was fitted on top of the implants, but no graft was placed in the gap. In the group number 3, no temporary crown, but they have grafted the gap, and then they've used just a healing abutment, slightly flared, just to contain the graft in position. And treatment group number 4 is when you do the extraction, place the implant, graft the gap, and then you use a temporary crown on in order to provisionalize your implant. So what were the results? So the control group, so the number 1 is just the one that when the tooth was extracted and the implant was placed, and basically the results here, if we look closely to them, I mean, the average is about 1 millimeter. So they've lost about 1 millimeter of buccolingual dimension. So this means that the tooth was extracted, the implant was placed, and nothing was done. So no temporary crown, no graft. So these are those numbers that I've shown you before. If we don't open a flap, we lose about 1 millimeter of buccolingual dimension. What happens if we move to group number 2? So what happens if, instead of just putting the healing abutment, we put the temporary crown on top of the implant? Well, the numbers, they start to improve. So from 1 millimeter of buccolingual resorption, we move to 0.7 and 0.8. And I apologize. So we move to 0.7, 0.8, and we can see here some improvement. So if we want to go a little bit more fancy, and if you put the temporary crown, the results, they start to show and to improve. What happens if we start to graft the gap? Well, in group number 3, no temporary crown was fitted, and the graft was used in the gap, and we can see here a good improvement to 0.3, 0.4, 0.2. I mean, this is quite remarkable. If in the beginning of the lecture I was talking to you about all those studies where we used to have about 5 millimeters of buccolingual resorption if we open a flap. Now here, if we don't open a flap, and if we are very or as atraumatic as we can, and place the implant and graft the gap, we get about 0.3, 0.4 millimeters of buccolingual resorption. So this is quite remarkable. I mean, this is this is simple. Here we don't need to do a temporary crown. So for the ones that don't feel comfortable in doing the temporary crown, at least you know that if you graft the gap, the results, they are very positive. But then, of course, the premium, let's say, is group number 4. This is when the numbers really they kind of like impressed, because we got zeros, and 0 in dentistry, as we all know, is very remarkable. So we can see several zeros. we have here 04, 03, 01. I mean, this is pretty much the situation that these patients they started with. So this is, and going back to that word that I've used in the beginning, predictability. So predictable. I mean, are we able to offer something predictable to our patients? I think we are, and I think if we follow the concept, which is being as atraumatic as we can, and I mean, before being atraumatic, of course, we need to do a good case selection, then being atraumatic, and then following the protocol that I've explained to you before. Ultimately, we'll place the implant, find the 3-2 rule, graft the gap, use the temporary crown. I mean, this is very, very, very positive results that we can see here. So we have the bones on variables, and the bones on variables are the thickness of the buccal plate, the size of the graft used, the flap, how we're going to do it. In this case, it's important to do it flapless. If you're going to use a platform switching connection. So all these bones on variables, they will have an impact on the final outcome of our treatment. But what about the soft tissue zone variables? And if you look into the third of those three articles, this is the main issue. I mean, the soft tissue is really what we want to try to keep stable in order to give that beautiful frame to our final implant crown. So one thing that is very important to explain, and that's one of the things that really made a difference when if you read the articles during this study, is the fact that when the graft was used on the gap, the graft was used all the way to the margin of the soft tissue. So instead of just leaving the graft material at the crest level, at the height of the buccal plate, it was placed all the way to the edge of the soft tissue, and we'll talk about it in a minute. So if we place the implant, if we are atraumatic, and if we place the implant and we just put a temporary crown on top of our implant, we get about 1 millimeter, 0.7 to 1 millimeter of buccal resorption. But if we add the graft, so if we graft the gap, we will get 0.2 millimeters in average of buccolingual change. So this is very positive, very encouraging, and this gives us some arguments to be able to offer predictable treatment plans to our patients when they meet here the criteria, of course. What kind of graft material should we use? I mean, this is something that still needs to be looked into in detail. Research needs to be done regarding this question. At this stage where we are, we believe that xenograft, because it's more stable, because it has a lower rate of resorption, could be ideal. And then, but then we have, as we know, other materials, allografts or cadaver bone, which could be used as well, could be mixed. I mean, then, of course, I don't want to give you my recipe. I want to try to stick as much as I can to the literature. So this would be 3 different options, and then I don't think that really autogenous bone would be really an option, unless you want to collect some bone while you're drilling, and then you mix it with the graft material that you're going to use. So because we graft the soft tissue all the way to the top, to the soft tissue margin, it's very common when you remove the temporary crown for the first time that you see this kind of image. And this is really something that we should not be scared about, we should not be bothered about, because what we see here is an entrapment of the bone particles into the soft tissue. So this will make the soft tissue thicker and more stable. In some situations, if the particles are very close to the surface, just very gently with a probe, we can just literally clean the ones that are loose, but this is not something that we should really remove. No, we do it on purpose. So we put the bone graft material all the way to the margin of the soft tissue. So again, another photo just showing it. Of course, that this is a photo taken while I removed the temporary crown for the first time. So this is still fresh. And then if for some reason, which I've done, you have to remove the final crown from the implant, even if it's a couple of years later, you'll see that you have a little bit less bone graft particles here so superficial, you have a bigger and high entrapment of the particles into the soft tissue. So this is something that we are not scared about. What about implant selection? I mean, as a principle, we all know that we should try to select an implant that is moderately, at least, tapered. Parallel wall implants, they offer a fantastic surface area, that's true, but they're it's very difficult to have a very high primary stability with those implants. So my choice for these kind of procedures is kind of like a tapered implant. And then we have other things that we need to look at when we select our implants. So it's the design of the implant, that's what I discussed with you about, the micro design, the design of the threads, what width should you use, what length. I mean, just for you to have an idea, usually the implant that I use most of the times for cases like this, the width is 3.7 millimeters. So that will allow me to have enough support to my crown, but at the same time I don't want to obliterate the socket. So it's very important that we have the right implant, and it has to be, I mean, we should measure more or less the tooth, and then we have to add at least a couple of millimeters in order to calculate the length of our implant. Then we should look into the surface of the implant. So there are here many things that are very relevant, and this is not just a screw that we're putting in a wall. We're using this in our patients, in human beings, so we have to be very meticulous about the type of products that we use in our patient's mouth, and try to understand how do they behave in the long run. So the implants that I've used, as I explained to you, the implant direct implants, they have a soluble blasted media, and this is basically a surface. There is a moderate rough surface, so it's not a smooth surface, it's not a crazy rough surface. It's a surface that will allow me to have a good bone to implant contact, but at the same time it gives me some confidence in terms of resistance to periimplantitis as well. The other thing that's talking about periimplantitis that I like to make sure is that the implants, my implants, they have always a little bit of a polished color, because this polished color will never be surrounded by bone. This will always be exposed. So for me, as a clinician, it's important to make sure that when the biological width forms here on the platform of the implant, the part that gets exposed to the bacteria is smooth, so we don't have here periimplantitis problems. As we all know, periimplantitis probably is the biggest nightmare of any implantologist. What about the temporary crown, provisional restoration? Why do we use it? We use it for tissue support. We use it for graft containment. So this is, in the end of the day, it's a fancy healing abutment that we're using here to make sure that the graft material stays inside of the gap. And also, I mean, for our patients, it's important to say that we use it also for cosmetic and social purposes. This is, I mean, this temporary crown was, in this specific case, was done by me. Actually, all of the temporary crowns that I'm showing you in the presentation were done by me. But the main thing that I want to show you here is that this is the kind of surface that I want. So I want a flat but supportive contour. I don't want to overbuild, because that's going to bring my tissue down. I don't want to create big concavities, because that will make the crown more difficult to clean. So I want to have a flat, supportive contour. I want to see my tissue. You will know when you fit the temporary crown, your tissue, the periimplant tissue, it always blanches a little bit, but we don't want to see excessive compression at the same time. So this is what I like to do. So the method that I like to use is basically the patient. Let's say that we agree the treatment plan, the patient is a candidate to have the immediate implant placed. So what I do in the first appointment is to take an impression of the patient's mouth. So I do an alternate impression, send to my lab, and then they're going to do an acrylic shell, as you can see here. And then that acrylic shell I will use to create the implant temporary crown. So then I'll use, once I place my implant, I will use PIC abutment. So the PIC is this very good material to work with temporary crowns, and it's cheap and it's resistant. So I place the implant, then I'll position my PIC abutment on my implant, and then what I will do is a pickup of the PIC abutment in order for me to finalize the temporary crown. So this is right after I pick up my temporary crown, so I like just then to connect an analog just to make it easier for me to manipulate the crown, and then all the work is done outside the mouth. So what I'm going to do here is just to add more acrylic, and then I'm going to trim back the temporary crown to the dimensions that I really want. So once I place my implant, the next step is to fabricate my temporary crown, and the last thing that I'll do is to position my graft in the gap so I don't contaminate my graft while I'm working with the temporary crown. So I don't want the acrylic to flow to the graft, so I always do the temporary crown first, and then I'll pack my graft into position. While I do the graft, by the way, just a curiosity, I like to fit the healing abutment on my implant just so I don't have bone particles flowing inside the implant. So that's one little trick that I like to do. So this is, as you can see, it's all about preservation, and what we want is to try to give back to the patient what the patient had initially, if there was not a major problem, like I explained to you before. So if the patient had an accident, the patient was happy, we want to preserve, at least we want to preserve what the patient has. So just to share with you a couple of my clinical cases. This first one, my patient Maria. She had her upper right tooth had a fracture. The crown kept coming out as well. She had many crowns done on this tooth, and the tooth had an indication to be extracted. And she has a very high smile, and so she's one of those cases that we think I better do it right, and I have just one opportunity to do this. So we start to scratch our head, we start to put all the numbers together to analyze the case and to do that assessment that I've explained to you before. And to be honest with you, sometimes I hear people saying that in high smile line cases when you should avoid to do these cases. My opinion is exactly the opposite. And it's the opposite because in my hands at least, I will be able to maintain the tissue in these very challenging cases in a much easier way if I do this protocol rather than if I just do the extraction and then I wait a couple of months and then I graft and then I place my implant and then I do a temporary crown and then I do the final crown. I mean, it's going to be 1.5 years to finish the case, and certainly I will have some issues with the soft tissue at the end. So a lot longer treatment plan, but it's not really the issue. It's not, that's not what I wanted to bring up. It's not so much the time, but it's more the fact that the end result will be a lot less predictable, more difficult to control. So this patient, she didn't have much bone, so that's why there was some trickiness here. We had enough basal bone here in order to place the implant, so the idea was to remove the tooth and to place our implant. So the tooth was removed atraumatically. After the tooth was removed, here I did my osteotomy and following the 3-2 concept, and then eventually I placed my implant. Once I placed my implant, then I started, this is me working here on the left hand side, then I started to create my temporary crown, so with the correct emergence and the correct surface here on the implant. Once I do my temporary crown, then I can graft the gap, as I explained before. And the last thing that I'll do is to fit the temporary crown. So once I fit the temporary crown, because I have the graft material all the way to the margin of the tissue, what I'll have to do is just to come here with my explorer and just remove the excessive bone that I have there. And then once I fit the crown, this is what we have. Patient comes back, and once the patient comes back, then we can see the soft tissue completely healed. So one thing that took us 2 appointments, well, one for the impression and another one to do the procedure itself. I think if we would have it done in another way, this would have taken a lot longer to complete the case. So and in a much less predictable way. So this is our temporary crown in position, and you will see now that once we remove the temporary crown, we can see the good scallop of our socket. It looks beautiful, and we don't need to do anything else. I mean, we don't have to. Let's say that I would have placed my implant, and at this stage I wanted to reshape the tissue. What we have to do? I mean, we need to numb the patient several times. That hurts. Then we need to use either acrylic or composite to reshape the crown. That's going to take time. Then the anesthetic will wear off. Then the patient will have pain. We'll have to take painkillers. I mean, here it's all done in one appointment, which is the appointment when we do the extraction and all the work, the implant placement and the graft and the temporary crown. So it's easy and predictable, and I think gives us some really good and beautiful results. So eventually, then we, according also to what the patient is interested in, we can offer different options in terms of final restoration. But we did our job. Even if the patient wants to have a PFM crown here done, I mean, we'll have to explain. That's not the ideal. But at least we did our job. The soft tissue is correct. The soft tissue is in position. And then it's just a matter of choosing the right material in order to conclude the case. So finish the case, pupils are in position, pupils are intact, and the patient was satisfied. And as you can see, the buccal plate is now a bit thicker, they were correctly positioned, and final X-ray. I like this image, this slide here, because it shows an evolution of the case. So this is the initial situation, this is with the temporary crown in position, and this is with the final crown. As you can see, the profile of the soft tissue is pretty stable. Of course, you can ask me, how is it going to be in the long run? She is my patient. This case was done 3 years ago, and it's still pretty stable. She's happy. She travels a lot, so she doesn't come back as often as I would like to. But honestly, this is stable, and I think really this is the future. And as you can see, she has a very high smile line. So I think if you have done the case in a different way, this it would be very difficult to get to this result. That's my opinion. I like this case. This is a different case. Nixon came to my practice. He basically had the tooth already, tooth number, the upper left one, so tooth number 21 had been already extracted somewhere else. He came, he had a flipper, he had a removable denture here done on the gap, and basically he was not happy. He wanted to have an implant, he wanted to have a fixed tooth. This was done. This photo was done 2 weeks after the extraction was done, and as you can see here, the papilla is starting to go away, the distal papilla. The mesial papilla is still partially there. So what I did with him is what I do with all my patients. I requested a CT scan, and on the CT scan, this is what I saw. I saw that we had there the buccal plate in position. So at least the dentist that removed the tooth was gentle enough to leave the buccal plate in position. And then I proposed to him, I said to him, look, we have this protocol. I've explained to him, I explained to him what would be the benefits. And I told him, look, we have very little to lose, because even if for some reason the implant fails, we just have to go back to where you are right now. So we're not going to get worse, we're just going to get better, and we may actually be able to deliver a good result in a very atraumatic way. So this was quite appealing. He understood the risks and the benefits, so he decided to move on with us. So a couple of days later, he came back, we placed the implant, and this is him with a temporary crown already in position. So as you can see here, the left papilla in between the tooth number 21 is slightly shorter than here the one on the left side of the screen, basically. But apart from that, we could, first of all, we gave him a fixed tooth, so he was all happy with that. But then apart from that, we could see that the soft tissue would respond well just by the way how it was putting a little bit of pressure on it. The day of the surgery, and then 4 months later, he comes back, the pupil was reforming there, so a very positive response of the soft tissue, and then with a final crowning position, I mean, we have a slight recession compared to tooth number 21, very acceptable. I mean, he doesn't show this, and he is very happy with the result, and I'm very happy with the result as well, because I think if we would have done in the case in another way, we wouldn't have had this kind of soft tissue profile. We would have to do a lot more procedures, and it would have been more complicated to manage the case. This is the final one again. And Carrie, again, another case. So upper right one had to be extracted, tooth was extracted, implant was placed, temporary crown was fabricated, and the graft was positioned in the gap. So this is the day of the surgery when she left, so we can still see, I mean, there is always a little bit of blood there. It's a bloodline, not really, there is bleeding. And then 4 months later she came back. There was a little inflammation here, some of the particles they were washing out. But then once I removed the temporary crown, I could just remove those loose particles, and then, as you will see, the quality of the tissue has really improved. So this is her with the final crown in position. The soft tissue is completely rehabilitated here, as you can see. The pupils are in position as well. And I've asked this patient to do again another post-op scan. Of course, I don't do this on a regular basis, but to these patients I've explained them that for academic purposes, I wanted just to be able to show in my lectures here the amount of bone that we gain. So she was happy. She was happy with the final outcome, and again we can see here the evolution of the case throughout the whole stages of the treatment. So going back to the protocol sequence, first of all we need to do a good case selection. Then we need to make sure that the extraction is as atraumatic as possible, so please don't raise any flap. We don't want to remove the periosteum from the bone. Then once we do that, we can start with our osteotomy, find the 3-2 rule. Don't forget that the first drill, the Lindemann burr, should go in a 45-degree angle, just to be able to create a stable perch point to start with our implant drills. Once we place the implant following the 3-2 rule, then I mean this number here, 40 newtons per centimeter of primary stability, it's a number that I think if you read more, if you are aware of the recent literature, this is a number that is well accepted by most of the surgeons all over the world. I mean, if we have at least 40 newtons per centimeter, we have enough stability in order to fabricate our temporary crown on top of the implant. After we place the implant, then we start with our temporary crown. One thing that I didn't mention is that it's critical that the temporary crown is screw retained, because we don't want to have any kind of cement getting mixed with the bone or with the bone graft. So even if for some reason the screw access hole is coming on the buccal of the crown, do screw retain. Even if you have to work out your magic with a bit of composite just to disguise the screw access hole, because that's critical. Then if you have to do the final crown cement retain, although I prefer to do screw retain, then do it. But for the temporary crown, you have to use a screw retain temporary crown. So once we do temporary crown, then we graft the gap, and then we'll fit the temporary crown, remove the excessive graft material from the edge of the soft tissue, and the last thing that we have to do is to remove all the occlusal contacts in the excursive movements, so the patient doesn't hit the crown accidentally. So all these cases, they are real cases done here in my practice. I have here these ones, I could have a lot more. And to be honest with you, the take-home message here has to be to follow the protocol to create. We need to follow the protocol in order to create predictable treatments and in order to give back to our patients those results that they're aiming, that they're looking after, without having to do that awkward and uncomfortable dance in the beginning. So we should feel comfortable and confident when we propose these treatment plans to our patients. In terms of future research, there are still lots of things that we need to look at. We need more long-term studies. Also, we need to see what will be the impact of platform switching to prevent recession in cases like this. I mean, all the literature that we have is not new. This has at least 10 to 15 years. All the literature shows that we have better results in terms of soft tissue and in terms of stability of the bone if we use a platform switching concept. Here, the one abutment one time would be the ideal solution, or at least to try to minimize as much as we can the number of disconnections of the crown or of the abutment to the implant. If we follow this protocol, I think we pretty much nail it, because although we have to disconnect it more than once, so in fact we have to disconnect it twice, it's a lot less rather than if we have to do the implant, place the implant, and do all sorts of grafts and soft tissue grafts and bone grafts in order to get to the final crown, and then we need to reshape the tissue. So how many times we'll have to disconnect? I mean, it's going to be a lot more than 2 for sure. And then the fourth thing that we need to look at, as I mentioned before, is the nature of the graft material. And with this, I would like to thank you for your attention, and I hope that this gave you a little bit of food for thought and a little bit of method as well